Hi, everyone. Thank you so much for joining me on this little presentation that we've got on. This is actually because of a current case that we've got going on in our hospital, where a talar injury was actually missed, and it's become a bit of a litigation. So I thought it was a good opportunity to actually have a look at these injuries, for the simple reason that they're not that common, but when they do occur, they can cause significant disability for the patient, significant trouble for them in terms of walking, recovery, stuff like that. And sometimes they do need surgical intervention as well. So in this case, the patient in the hospital suffered a talar neck fracture, and it was missed. I can understand why, having looked at the x-rays after that, but clinically, it was suspicious, and amazingly, even the patient came back second time, and that's when CT actually confirmed it, and the patient now has had an issue with work, and that's so it's become a bit of a problem. So this is just to try and give you an idea of how we see talar fractures and how they actually work. So this is your talus, in case you've forgotten. All right, so this is your talus that sits just above your calcaneus, and just behind your what you call it. What am I trying to say now? It'll be behind your cuboidal bone that's sitting over there. Then, of course, you've got your cuneiforms and your navicular as well over there, right? So this is basically what the talus looks like. Now, if you had to look at the talus is basically a connector between the major bones of the ankle, such as the calcaneus, cuboidal, navicular, cuneiforms, and the tibia and the fibula. It provides that bridge between these two. So it's actually quite well protected. And generally, injuries would involve the tibia and the fibula, or it will involve one of the metatarsals over here. And actually, these few bones here, the calcaneus, talus, navicular, and cuboidal, are not commonly fractured, but when they do, it produces a significant disability for the patient, because the ability to walk and have a stable foot is completely taken away. So that's where you have a lot of issues with the talus. So if you haven't had a good look at the talus, this is a good time to have a good look at it. But most of us will see it on X-ray and recognize it there. All right. So what we're going to look at first is we're going to look at a talar dome fracture. So let's just go ahead and have a look at the fracture itself, right? So talar dome fractures can be of two types. Now, this you can see you've got a straight line going through the talus, and sometimes you also have just a little fracture that may run through there, or you may have, a separation of the bone, and it actually causes the periosteum or the top part of it to actually lift up. So these are the different types that you get. Now, in this case, you can see the talar dome fracture quite easily, because it's quite a significant one. But if you're not looking for it, it's quite easy to miss as well. And it's a case of, if you don't see other fractures, or you, for instance, the tibia and the fibula are looking fine, have a look at the talus. There may be something going on over there. And you may often find that your patient does have a fracture in that case. So I just want to go back one, just to talk about the talar dome fracture. Sorry about that. I think I may have arranged these slides a bit in an incorrect manner. But anyway, so in terms of imaging, radiography, which is normal X-rays, are normally enough. AP, mortise, and lateral views are normally sufficient. And CT scan sometimes is needed with subtle fractures. And especially if we don't know if it runs into one of the other bones, then, you need to have a look. Now, like I say, it's an uncommon fracture site, but that's not to say it doesn't fracture. Uncommon doesn't mean it doesn't happen. It just means it's a more well-protected bone, so it tends to not fracture as commonly. So how does it fracture? So how do you get talar dome fractures? That is, direct axial roll, or the axial load, or ankle twisting. So those are quite easy to understand. So direct axial load, it would normally come inferiorly, So from the heel up, if there's a mechanism of injury that way, or severe twist of the ankle, although ankle twisting will normally result in other fractures as well. So you have to assess for it quite a bit. And the treatment is actually based on the degree of displacement. So majority of these patients will be treated conservatively, but if the displacement is quite bad, you know, one of the other things to remember is that if you have a tibial fracture and fibular fracture and your talus is displaced from here, that's also quite significant, you know, so that's called a talar shift. And you know, even though it doesn't fall specifically under talar fractures, but that also, you know, increases the severity of your fibula and tibular fractures, tibia fractures. I'm saying tibula, like a lot of people will get those mixed up sometimes. So now we're going to have a look at another one, which is a talar dome osteochondral lesion. So let's have a look at it first, and then we'll come back. So this is similar to what I was telling you all about. So this is where you get the osteochondral lesion. So these are fractures that occur along the top of the talus, right? Along that talar, you know, the superior part of the talus. And this one is quite easy to see now that there's an arrow there. But, you know, take out that arrow and suddenly, now, is there a fracture there? You know, what else are you looking at? You know, so, you know, it can get quite difficult sometimes. And what I would suggest is that if you suspect it, the best thing to do is actually so generally with these types of lesions, then normally, you know, your X-ray should be sufficient, but MRI is the study of choice. Even though many of us may not have access to it, CTs can also show it up, of course, you know. So this is resulting from trauma disrupting blood flow or a subchondral fracture. So it just depends on, you know, the exact mechanisms that are occurring over there, because you have quite a significant blood supply that runs through that area. And should that blood supply cut off, you know, and it's a watershed area, it can cause problems, you know. So generally the symptoms are pain, reduced range of motion, unable to walk properly. So you've got to examine the talus in plantar flexion and dorsiflexion, and you're going to palpate for pain, you know, and sometimes you may actually feel a swelling, although that isn't very common, I must be honest, you know. So this is a talar dome osteochondral lesion. And again, this is not the type of thing you're going to run into every day, but if you work long enough, you will eventually see one of these. Now let's look at the talar neck. So talar neck fractures, you know, there's two types. You basically get subtle fractures and you get very obvious fractures. Now, obvious fractures of the talus neck, which is here, this is the talar neck that's sitting over there. As you can see on a plain radiograph, now this is one that I've taken from a book, but this was similar to the patient that I was talking about. And if you look at the plain radiograph, it's very difficult to actually make out that there is a fracture here. Unless you look very closely, you can start to notice that the cortex here is not, you know, it's not continuous. It's actually got a little break over there. And when the patient had the CT scan, that's when you can see the actual fracture that was running through. So these types of patients, generally what will happen is that they're unable to dorsiflex and they're unable to plantar flex. They have significant soft tissue swelling. There may be bruising, as you can see on this foot as well. So these are the types of patients where if you suspect something, but you can't exactly see a fracture, then there's, sorry, let me get back to that. There's two possibilities. Number one, there is a subtle fracture, or number two, you've got ligament and tendon injuries. So those are the two things that you have to consider in a patient such as this. Those are the things that you must really look out for when you have these types of foot x-rays in front of you. So radiographs normally sufficient, CTs for detailed assessment. So how is it? It's normally a high energy injury with the foot in dorsiflexion. You do have the Hawkins classification, which I think I've got it on a bit later. I've got it somewhere there. But in any case, when you do orthopedics, and you do learn the Hawkins classification to predict osteonecrosis, and there's a high risk of talar dome osteonecrosis because, like I said, the talus is also a watershed area for blood supply. So generally, it's reduction and fixation, and emergent reduction for displaced fractures is normally done quite commonly, and CT is normally used for operative planning. My apologies for that noise in the background. It's just one of the machines that in our office that's just running. And on this, obvious fracture, you can see there's a lot of displacement. Your calcaneus has moved. Your talus is completely out. You may have multiple fractures that are running here. So, these are much easier to spot. And these, as you can see, it can be very difficult. Even experienced people will look at this and not necessarily pick it up because it's not a common injury. So that's why I just wanted to highlight to you that, if a patient presents with pain, can't dorsiflex, can't plantarflex, can't bear weight on the foot, you've got to think about ligament injuries and possible subtle fractures. Because the fracture could be here in the navicular, it could be here in the cuboidal, the cuneiforms, the calcaneus. There's lots of injuries that could occur. And then you've got your tibial ligaments, you've got your fibular ligaments, as well, that are going over there. So, you've got quite a bit that's going on over there. All right. And now we're going to look at another one, which is the lateral process of the talus. So these, as you can see, they're quite difficult to pick out, generally because it can mix in very well with the soft tissue. So I just wanted to show you an example of one where you can see the fracture line running through there, and you can see a slight piece that has come out over there. But these are very, very subtle fractures. So normally, if it's a very well-defined fracture, it should be easy to pick up. But I must be honest, in clinical practice, CTs are more commonly used because the patient will have the same problem. They'll have difficulty with inversion and eversion, difficulty with dorsiflexion, plantarflexion. They're unable to put their foot down. They're unable to walk properly, or they're walking with great difficulty, but you can't seem to see something on X-ray. This is when you need to hand the patient over or put them in a back slab at least and try and get somebody more experienced or an orthopod themselves to have a look at it, So it's commonly known as a snowboarding fracture because it tends to happen to snowboarders more often. So there's anterolateral ankle pain, and it's often misdiagnosed as an ankle sprain. So these patients, you may send them home and they keep on coming back. They're not getting better. So that's how you need to think about, okay, could this be a missed fracture? And that applies to all fractures, actually. If a patient, you've treated them, you didn't see anything on the X-ray, but they've come back, they're obviously still in pain, they're obviously still struggling. You repeat the X-ray, you still can't see anything. Don't just assume that everything is okay. At that point, you've got to say, okay, there's two possibilities. Number one, I'm missing something. Or number two, the patient has a low threshold for pain. But if I've missed something, I need somebody else to have a look. So if the patient's coming for the second or third time, get them to somebody more experienced, somebody who's maybe in like an orthopedic department in this case, and get them to have a look as well, And so the treatment is either POP, or you can put them in, they need operative fixation. And one thing to remember is that patients with anterolateral ankle pain, it's very possible that they may have a lateral process fracture of the talus going on over there. Okay, so let's just look at the subtalar dislocation. My apologies that I've actually put I didn't realize that I mixed up the slides so badly. So here you can see a talar dislocation, all right, subtalar dislocation. So the tibia, the fibula also slightly displaced, and the talus has come out completely. In fact, you can see the calcaneus popping out there at the bottom. Here in this case, you can see the tibia, fibula actually well attached on their articular surfaces, but everything else has detached from under that. And clinically, when you see this, you're not going to miss it because there's such a severe deformity that occurs that you are going to notice it. But at least now you know that it's called a subtalar dislocation. So AP, mortise, and lateral views are quite good. CT especially for operative planning and things like that. The clinical implications, like I said, there's obvious foot deformity and pain, and it's often associated with neurovascular injury. So it requires emergent reduction. That is something, sorry, I forgot to mention. So you have to, in any of these cases, you must make sure that your distal pulses are always present and good, in any of these joint injuries, and especially if there are dislocations and fractures, that's something that you can be held liable for. And unfortunate parties, and most of us will know that medicine has become much more defensive now. Whereas before, not to say that we used to just treat patients and let them go, but we were allowed to make mistakes without as severe repercussions as what they are now. Nowadays, people realize that something goes wrong. They have the opportunity to sue. They have the opportunity to be financially compensated, which is their right. I'm not saying it's not their right, but it has become much more litigious. So even minor injuries or things that are easily missed, when you are taken up and you have to face disciplinary or HPCSA, things like that, if you haven't done the basics, it's very hard to defend yourself. So always remember the basics of checking everything, making sure distal pulses are there, making sure the patient is neurologically intact, and documentation. That's the best thing I can advise you to. So the treatment is based on the presence of associated fractures, but generally you've got to reduce this. The reduction is quite easy. All that you do, especially if your patient doesn't have a pulse, basically what you're going to do is you're going to pull down on the part of the leg with counter traction moving up this way. And what will happen is the calcaneal articular surface will normally come into contact here, and not necessarily the others. But generally, your calcaneus will come in, and if you manage to get good enough traction and pull all of these bones below the foot as far as you can, you may get a proper full reduction. If you don't, it's very important to know that you need an urgent CT angiogram, or you need an orthopod to try urgent reduction in order to be able to get that blood supply back. But luckily, this is also not a common injury. When I have seen it, it's very horrible to look at. I'll be honest with you. It's one of those things that makes your skin crawl because you can't imagine the amount of pain that these patients are in. All right. So this is a subtalar dislocation, as you can see over there. So I hope you guys enjoyed it, and my apologies for the circumstances around pre-recording this. But like I say, I hope you guys all enjoyed it. My apologies for the phone ringing in the background. And if there's any questions, more than welcome to ask me on the group, and WhatsApp me and things like that. But I hope you guys enjoyed it. Okay, and until we meet again, hopefully the next time I will try and do the ECGs as promised. Okay, thank you. Bye.